In my clinical practice, I have used regorafenib so far mainly or mostly in patients with colorectal cancer because it's not yet approved for patients with hepatocellular carcinoma so far. But we participated in both trials, in the CORRECT trial for patients with colorectal cancer and also in the resource study for patients with HCC. When we think about patients with colorectal cancer that are not used to multi-tyrosine kinase inhibitors, of course we see quite a considerable number of side effects, and side effects management is an important part of our treatments in this group of patients. So when we started with the resource study, I was not really sure whether this drug is a good drug for patients with HCC, liver cirrhosis, poor liver function after sorafenib, and I was a little bit skeptical about it. But from my experience in the resource study was quite different, and I think patients that are used to sorafenib tolerate regorafenib much better than patients that have never been treated before with multi-tyrosine kinase inhibitors. So in contrast to my experience in colorectal cancer, I think regorafenib is much better tolerated in patients with HCC that do tolerate sorafenib in first line. So here my experience was really better, and I'm looking forward to use it now in the daily clinical practice, and we will see whether we get similar results as we have, or as I have seen it in the resource study.
As we look at the side effect profile of regorafenib, it obviously has some overlap with sorafenib. In the colon cancer space where it's used, often these patients are relatively heavily pretreated with chemotherapy over the course of several months, if not years. And I think the tolerability in that population is different than in the resource population. Unlike other studies in liver cancer, which would enroll patients who did not tolerate sorafenib, the resource study had a requirement that patients had to be on sorafenib for a certain period of time at a certain dose. And by doing that, I think patients and doctors have a certain level of comfort with managing the toxicities we see with regorafenib. That's different than in the colon cancer space, where there is not necessarily overlapping side effects between regorafenib and the EGFR drugs or bevacizumab or even the cytotoxics that are used. And that doctors should not necessarily expect to see the same level of intolerance that they see in the colon cancer population in the liver cancer population. That they should have some comfort in how to manage these side effects in the context of patients being on sorafenib. And again, when indicated, dose reductions, using Imodium, urea-based creams for hand-foot syndrome. Fatigue is often something difficult for us to manage because there's not a medication that helps per se, but advising patients on good sleeping habits, and again, at times, taking a break or even a dose reduction. Keep in mind, in the liver cancer cohort, patients do take it for 3 weeks on and 1 week off, and taking advantage of that week off to get rest.